Glasses off. Good morning, everybody. We can start in a minute if everybody's at their seats. Thank you. Welcome to the Audit Committee meeting of Monday, the 30th of April, 2018. And I'll ask the committee for any declarations of interest. None? Thank you. Can we confirm the confidential minutes of the 30th of November 2017? They've been distributed to you in an envelope. Please ensure that you return these envelopes to the coordinator by the end of the meeting. If you'd like to wait to the end of the meeting to approve the minutes, or we can confirm them now. It's your choice. Everybody's good? Okay. Confirmed? Thank you. Item number 1 of the agenda is the reports on investigations into long-term care homes. The Auditor General has a presentation, so we can, and you've also have a motion, to add this supporting documentation to the report. Councillor Cloutier, please read that motion.
Merci, Monsieur le Président. Attendu que le document à l'appui ci-dessous n'a pas été distribué avec l'ordre du jour, Bureau du vérificateur général, rapport sur les enquêtes menées dans les foyers de soins de longue durée. Therefore, be it resolved that the Audit Committee approve the addition of this document for consideration by the Committee at today's meeting pursuant to Section 89.3 of the Procedures Bylaw, Bylaw 2016-377.
Is that motion carried? Yes. Carried. Thank you. Mr. Hughes, would you like to proceed with your presentation?
Thank you, Mr. Chair. Merci, Monsieur le Président. Je vous présente ce moment à ma gauche Yves Santoro, assistant administratif, et Madame Sonia Brennan, vérificateur général adjoint. Good morning, Mr. Chair, members of the Audit Committee, councillors. I'd like to introduce Inez Santoro, our Administrative Assistant, on my left, and Sonia Brennan, Deputy Auditor General, on my right. They'll both be helping with the presentation today. Monsieur le Président, normalement, on commence avec les aides-mémoires. Et aujourd'hui, c'est un rappel que, selon la loi sur les municipalités, une municipalité peut nommer un vérificateur général qui est chargé d'aider les conseils et ses administrateurs à assumer la responsabilité de la qualité de la gérance des fonds. Et aussi, le vérificateur général doit travailler indépendant, comme une façon indépendante. As usual, we begin the Audit Committee with a little reminder, and today we just taking us back to the Municipal Act, where the authority for my office comes from, and that is that a municipality may appoint an Auditor General who reports to Council and is responsible for assisting the Council in holding itself and its administrators accountable for the quality of stewardship over funds, and that I must perform that task in an independent manner. On a 3 types de vérifications que nous faisons. Des vérifications financières, des vérifications de rendement, des vérifications aussi de la conformité. Aussi, mon bureau gérait la ligne directe des fraudes et menait des enquêtes. There are 3 types of audits that are carried on by this office. There are financial audits, there are performance or value for money audits, and compliance audits. The other responsibility for this office is the administration of the Fraud and Waste Hotline, and of course, we carry out any investigations that come from the Fraud and Waste Hotline. Les 2 rapports aujourd'hui sont les résultats des 2 de nos responsabilités. Nous avons fait des enquêtes après les signalements de la ligne directe et aussi nous avons fait une vérification de la conformité avec les lois, politiques et procédures. These 2 reports today are related to 2 of our functions. The first is that we performed a couple of investigations that came out of reports to the Fraud and Waste Hotline, and also our role as compliance auditor. Is the city in compliance with the legislation, specifically the Long-Term Care Homes Act, and also our own policies and procedures. Today, we have two reports. The first report is a review of medication management at long-term care homes, and the second is an investigation into the reporting of an incident at a City of Ottawa long-term care home. We'll begin with the review of medication management. Cet examen a été mené en réponse aux problèmes signalés à la ligne directe. Les travaux ont commencé à l'été 2017. Quelques semaines plus tard, un ordre de revoir du directeur a été lancé par le ministère de la Santé et des soins de longue durée de l'Ontario pour 3 des 4 foyers administrés par la Ville. L'examen avait pour but de déterminer si les foyers ont des pratiques, des procédures et des moyens de contrôle adéquats pour leur système de gestion des médicaments. The fraud and waste line received a couple of reports in 2017. We began our work in the summer of 2017, and you'll recall that shortly after we began that work, the ministry issued a director referral order for 3 of the 4 City of Ottawa long-term care homes. Accordingly, we delayed our work until January 2018. Our objective in this investigation was to determine if the long-term care homes have appropriate practices, procedures, and controls in relation to medication management system. And of course, we were looking for to ensure that the city was in compliance with the Long-Term Care Homes Act, the regulations, and any policies and procedures that exist. We selected 2 homes for evaluation, the Peter D. Clark and Gary J. Armstrong homes. Our review covered areas of medication management, including governance, acquisition and receipt, storage, administration, destruction and disposal, and emergency supply. We made a significant investment into this investigation. In addition to interviews and documentation review, the audit team spent more than 5 days at each home conducting direct observation of personnel during the performance of their tasks in relation to medication management. Now, at this point, Mr. Chair, I'd like to thank staff for their cooperation and, quite frankly, their candid comments. It made our work a lot easier, and the cooperation was certainly appreciated. Nos principales constatations, par exemple, il y a des lacunes dans les politiques et les procédures en comparaison avec les règlements de la loi. Pour vérifier si la Ville est en conformité avec la loi, par exemple, un foyer doit avoir un système interdisciplinaire de gestion des médicaments. Il doit être efficace et les médicaments doivent utiliser au foyer doivent être acquis, reçus, préparés, entreposés, administrés, détruits et éliminés de façon rigoureuse. Under the Long-Term Care Homes Act, a long-term care home must have an interdisciplinary medication management system, and that system must include the accurate acquisition, receipt, dispensing, storage, administration, and destruction and disposal of medication. A lot of them may seem logical to all of us. It's no different than any activity, but in this case, you're dealing with medication, and they must be the systems must be more rigorous than you would see in any other instance with any other type of inventory. The homes must have comprehensive policies and procedures that not only documented, they must be clearly understood to meet the requirements of the regulation. The staff involved have to be accredited to carry out their duties. And there must be an interdisciplinary team that meets at least quarterly that evaluates the effectiveness of the home's medication management system. We found some gaps in the city's policy and procedures when we compared them to the regulations. For example, we found that there was no procedure to address the implementation of corrective actions stemming from audits or reviews of destruction and disposal of medications. You may not be aware, but the pharmacy service provider conducts quality improvement reviews. We reviewed a sample and noted that there were recurring findings and that there was nothing to show that corrective actions were implemented, which the regulation requires. For the most part, other than the lack of enforcement of some of the policies and procedures, we found that the policy and procedures that did exist were adequate, but as we've stated, they must be followed. Concernant l'acquisition et réception des médicaments, le foyer doit avoir des moyens de contrôle régissant la commande et la réception des médicaments par le personnel autorisé. Nous avons constaté que les reçus de livraison sont signés par les personnels, mais l'illisibilité des initiales et des signatures ne nous permet pas de déterminer si les signataires étaient des employés autorisés.
Thank you. With respect to acquisition and receipt of medication, the Act requires that all drugs received for use at long-term care homes are acquired based on resident usage. The Act also requires that there are controls in place to govern the ordering and receipt of drugs by authorized personnel only, and that there's a fully maintained and detailed drug record in place. For drug receipt, this usually happens on the evening shift, but the verification process, so checking the receipt against the items received, is not done at that time. It's done later in the evening on the night shift. We did look at the records and found that some discrepancies do occur. Ideally, the drugs should be verified at the time of receipt. This ensures that any discrepancies are communicated on a timely basis to the pharmacy rather than having been signed as received and then dealing with discrepancies later on. Drug receipts are signed by staff, but we couldn't determine whether or not those staff were authorized because the initials or signatures were illegible. There's a master signature list that's kept, but we couldn't match the signatures or initials to that list. With respect to safeguarding, we observed that the drug deliveries were left unattended at an open location, while the pharmacy representative made deliveries to the units. We also observed drugs left at a second unsecured location, while the rep went to locate the nurse to take custody of the drugs. The packages should be placed in a secure location at all times upon receipt. And this is important as we're spending time in these homes. They're busy places. There are staff, there are visitors, there are volunteers, there are vendors. So there's a lot of people that are in the homes, and it's important that the drugs are secured at all times and in compliance with the regulation as well. We also observed that resident charts were left in areas that were at times unlocked and unattended, and that's private information. It's important that that's secured as well. With respect to the storage of medications, the Act requires that controls are in place to ensure that all controlled and non-controlled drugs are stored and safeguarded and accessible only to authorized individuals. They need to have adequate procedures in place to reconcile controlled drug inventories monthly and identify discrepancies on a timely basis. The homes are also required to ensure that drugs that are stored are secured and locked at all times when not in use, and access to these areas must be restricted. We found that storage units that hold a week's supply of medications for each resident were observed to be left at times unlocked and unattended. Each home also has a government pharmacy. This provides access to non-prescription drugs in bulk quantities. The government pharmacies are in areas that are separate from other medication storage areas. At both homes, we found no adequate systems in place to document the acquisition, the removal, or the use of those drugs. There was no physical stock taking or reconciliation done to identify if there were any differences between the quantities on hand versus what was dispensed. This allows the opportunity for unauthorized removal without notice or accountability, and it increases the risk of drug diversion. We found similar issues and risks in excess medication stock areas as well. The medication rooms and the government pharmacies have no cameras. Given the volume of the medication that's stored, cameras would provide added security and again reduce the risk of drug diversion. With respect to the administration of medication, the Act requires that there are controls in place to ensure that the drugs administered to the residents are accurate and are performed by authorized individuals. We observed the home's practices to determine whether or not they were in keeping with the regulation as well as the city's policies and procedures. This included the examination of the medical administration records. They're also referred to as MARs. A MAR is a record of all medications prescribed to each resident. The pharmacy provider produces these forms for the homes. There is one MAR per resident, and we can see them in binders where the nurses are when they're carrying out the administration of medication. When the nurse administers the medication to the resident, they're responsible to initial the MAR to show evidence that this occurred. So one of the requirements is for authorized individuals to be administering the medication. Based on our review and similar to a similar finding, we were unable to determine that the initials or the signatures matched the master signature list. So we couldn't tell for certain whether or not it was an authorized staff member that was administering the drugs. Why is this a problem? Should there be any issues with respect to drug administration, it allows the city to provide evidence that an authorized employee did perform that activity. We also examined how it was ensured that the right resident receives the right medication. I just want to read a small excerpt from the city's policies on this. And it says, if unable to self-identify, look at the resident picture in the MAR. So the MAR form has a photo of the resident. And verify with bracelet or armband. We observed several medication rounds. And we noted that the nurses generally address residents by their name, and those residents who are verbal acknowledged the nurse, and that serves as confirmation that the right person received the right medication. However, for the residents who were nonverbal, they were not identified using a second form of identification, the bracelet. Even though they didn't respond to their names, and oftentimes they were in a forward position where they were slouching, so it wasn't easy to see their faces and match it with a photo. We also noticed in several instances residents who were not wearing the bracelets or armbands. So although the staff has good familiarity with the residents, there's also a significant amount of staff turnover, and this would impact the risk of errors in this situation. When we reviewed the documentation to look for sign-off of the medications being administered, we found that in some instances, and it was a very small amount, that there was no notation to indicate that the drug had been administered. We cross-checked the instances that we found against the resident records to see if there was an incident or a hospitalization. There was a cause that would explain the medication not being administered. We did not find causes in those situations. We did notice that the nurses were frequently interrupted during medication rounds, which could be a factor in the records not being updated. However, the missing notations could also suggest that the drugs just were not administered. With respect to the destruction and disposal of drugs at long-term care homes, the Act requires that each home has a drug destruction and disposal system to identify and destroy and dispose of drugs that meet the criteria for destruction. So it would be items that are expired, discharged, discontinued, etc. And on an annual basis, each home's system is audited for adherence and effectiveness, and the results are documented. And this is right from the Long-Term Care Homes Act. We found that non-controlled drugs are not destroyed according to the city's policies and procedures. The policy states that at the time of disposal, the medication must be removed from its packaging with a second team member, and the surplus medication should be placed in a tamper-proof disposable bin supplied. And that's the photo that you see here. Those are the bins, and you can see the medication is still in its packaging. The second part of the procedure states that water will be poured into the bin to render the medication inactive before being removed from the home area. Based on our observations, and you can see one here, in several instances, the non-controlled drugs were in the disposal bins in their original packaging without any liquid. They weren't sealed, and on separate occasions, the auditors were able to open the bins, which again shows risk of potential drug diversion in the homes. As well, the regulation requires that all drugs are destroyed in teams. Based on our interviews with personnel, after the drugs have been identified for destruction, one nurse takes the drugs to the destruction bins. So it's not done in teams all the way to the end of the process. Again, this increases the risk of drug diversion. As well, we noticed the bins with the non-controlled substances. They're removed from the medication rooms and they're placed in a designated storage area. Then they're moved to an unsecured holding area to await pickup by a third-party contractor. Depending on the schedule, the bins can be there for a number of days before pickup. And the holding areas are used by other service providers. Once again, this is another area where the drugs are unsecured and there's a risk for diversion.
Tous les foyers réserve de médicaments contrôlés et non contrôlés. C'est nécessaire parce qu'à l'occasion, des résidents ont besoin d'un médicament qui ne fait pas normalement partie de son régime médicamenteux. Donc, on s'appelle cette réserve la réserve de médicaments en cas d'urgence. L'examen a révélé des anomalies dans la consignation au registre sur les médicaments pour les deux foyers. Dans certains cas, rien n'avait été noté pour justifier le retrait du médicament. Dans d'autres cas, nous avons relevé des erreurs mathématiques dans le calcul des médicaments restants. Aussi, aucun inventaire périodique du stock de médicaments dans la réserve n'a été réalisé et aucun rapprochement n'a été effectué. Le manque actuel de moyens de contrôle adéquats fait grimper les risques de détournement des médicaments. La direction est d'accord avec toutes nos 17 recommandations. Every home has an emergency drug supply in case a resident has a need for medication outside of their normal medication regime. To ensure that the home was in conformity with the regulation, we looked to ensure that only approved drugs were maintained in the emergency drug supply, that the supply was clearly located, labeled, secured, tracked, and documented at all times to prevent unauthorized access and distribution of drugs. A medication log is maintained of each drug in the emergency drug supply. Each time a drug is removed from the emergency drug supply, the resident for whom it was removed should be documented and an emergency replacement form completed and faxed to the pharmacy to replenish the supply for that particular drug. In our review of the logs, we found inaccuracies in the record keeping for the drugs at both homes. In some examples, there was no documentation to support the purpose for the removal of the drugs from inventory. In other instances, there were mathematical errors for calculating the balance on hand. As well, when the pharmacy service provider does its reviews, excess drugs or expired drugs may be removed by the pharmacy. In this instance, there is no way to verify who removed the drugs. We also found that there was no periodic stock taking of the drugs in the supply, nor was there any reconciliation. Unfortunately, the lack of adequate controls currently in place makes the risk of drug diversion very high. Each drug in the emergency drug supply also has an approved maximum quantity of drugs that should be held at any particular time. We found that where the record reflected drug quantities, we found in the record that there were some instances where the drug quantities on hand exceeded that maximum quantity. And I can say that management agreed with all 17 of our recommendations in the review of medication management. En conclusion, les médicaments ne sont pas bien protégés contre le vol et l'utilisation inappropriée. Nos recommandations aideront donc à combler les lacunes dans le respect des procédures à réduire les risques de détournement des médicaments et à protéger les résidents du foyer. In conclusion, Mr. Chair, we found that the city needs to strengthen controls over the management of medication in long-term care homes to address the issues found with current practices. They must do this in order to reduce the risk of drug diversion and improve the long-term care homes practices. Although the existing policies and procedures are adequate to guide the functions in relation to medication management, they're not being followed in a number of areas. Within the key cycles of the medication management system, we noted numerous deficiencies in the long-term care homes practices that increase the risk of drug diversion, specifically related to the storage, destruction, and disposal of drugs with the emergency drug supply. The recommendations that we made mitigate the risk of drug diversion and contribute to the safety of legislation of the long-term care homes and ensure that the homes are in compliance with the legislation. Now moving on to the investigation into a long-term care home.
Mr. Auditor General, would you like to take questions on that first part of the report before you move on to the second report? It's your choice.
It's the will of the committee.
Okay. Would the
Chair.
committee like to ask what? Okay. All right. Why don't we take a pause on the report here and ask some questions on what you just brought forward. So, Councillor El-Sentiri, you were first. Anybody else?
Thank you, Mr. Chair, and thank you, Mr. Hughes and your team. Interested in the medication, Mr. Hughes, when you talk about the management of the medication, so it leaves it open to many speculation, either disappearance, theft, or been given to patient without proper record. Can you explain a little bit more, like what could, like I understand it could be many area, and I'm surprised to hear from you there's no cameras in those facilities, because there's cameras, surely to God, everywhere except in the bathrooms these days. So how could a facility like this doesn't have a camera to find out how the medication been allocated?
Thank you, Mr. Chair. Through you to the Councillor, there is an entire system of control that is in place from the moment that the medications arrive at the long-term care home through to either the dispensing to the resident or the destruction of the medication that isn't used. So that includes its movement, its initial storage within the long-term care home, its movement to the unit, the area where it would be used, and the controls while it's in storage, and then the controls after it's designated for destruction, for example. And what we found was that the processes and policies that are in place are in conformity with the legislation, but a lot of the procedures are not being followed. There's no one checking on a regular basis to ensure that all of the procedures are followed. And when that happens, that means that medication could be lost or could be stolen. And without things like stock taking and reconciliations, you're not even aware that medications are missing. You don't know. You also don't know when they could have gone missing, and that's a concern. And then, of course, there are other things that could be done to improve the protection over the medication while it's in storage, and those are things like cameras, as was discussed.
If I can follow up, Mr. Chair, I find it is hard to digest, because we hear even on social media, on radio, TV, telling parents to put their medication under lock, even if they have away from their own kids, and I find it in this area where some of the medication is not even been in the control of someone, and we heard from the deputy auditor when said the drug's been taken and put in places insecure and waiting for a third party to pick up, and and all make it almost ready for anyone wants to basically tamper with. And I don't understand. And I heard what you said. There's a control management in place, but it's not been followed. I think that's even worse. So we already have those measures in place, but if they're not been followed, that's I'm not sure. Where's management role here? Not making sure the policy been followed in those areas. And I still need to understand a question about the camera. Why there is no camera in those facilities?
When you introduce a system of control, it's imperative that people, first of all, be familiar with it, they understand it, and that on a regular basis, steps are being taken to ensure that management is checking to ensure that staff are following those procedures. And when staff knows that people are following those procedures, first of all, they'll be reminded to follow them. And in the rare case where you have an individual who will help themselves to something that they're not entitled to, if they're aware that there is an opportunity to remove something without anyone's knowledge, they will avail themselves of that opportunity. So it is imperative that the systems that are in place, which are well designed, that they be followed, and that checks be done on a regular basis to ensure that they are being followed.
Is it management going to answer the question about the camera? Why camera was not installed in those areas? Can we ask staff why camera was not installed in the area where those drugs been stored or been given? Or I'm just interested because we have cameras almost everywhere in almost every hallway. Why was no camera in place to make sure the people who's managing those drugs follow the procedures and follow the policy you have in place?
One of the recommendations from the Auditor General is to put cameras in those rooms, and we will absolutely review that in terms of putting cameras to ensure that there is no diversion of any of the prescriptions and the medications. But at this point, we do not have them. We have them in hallways and in some of the residents' rooms at the request of the families, but not in those rooms. But we will be considering them going forward.
Okay, thank you. Thank you, Mr. Chair.
Thank you, Councillor Al-Shatturi. Councillor Cloutier.
Thank you, Chair Hubley. Just following up on Councillor El-Shantiri's question about cameras, he's referring to recommendation 10 and management's response is a risk-cost-benefit analysis will be completed by Q2 2019. That's a year from now. It's an important issue. I share Councillor El-Shantiri's concern. Why can't that be acted on? Why can't we not have that analysis done more quickly?
We have received feedback from 5 different sources since July of last year, and CPS will receive later today a consolidated work plan that reflects all of those recommendations, and it's upwards of 80 different recommendations. What we're doing is trying to prioritize those that are more closely related to the care and services of our residents and families as a priority, and looking at those other recommendations, some of which came out of the 2 audits that you'll hear about this morning. If we can move forward on these, we certainly will. And when we talk about some of the diversion, in terms of missing medication, we do find that we may miss a dose. Those that when they go missing, we actually record those. And so in terms of risk, at this point, it is low. But we can certainly look at moving it forward based on any recommendation we receive from committee.
I think if we look at the whole gamut of recommendations, it's an inventory control issue. And I guess I'm addressing management now. It's an inventory control issue. it's not that complex. It's a pretty dangerous substance. What type of drugs are, I guess to the Auditor General or to Janice, what type of drugs are we talking about? Can you give us some of the names or their class?
Mr. Chair, there are two. Management can correct me if I'm wrong. There are two classes, controlled and non-controlled, and then the controlled ones would include opioids, for example, pain medication, and then there are the non-controlled drugs. And there are two policies for disposal of each of those types of drugs.
Okay.
The recommendations, the observations that we made on the destruction and disposal of drugs related to the non-controlled drugs, which, although not opioids, still have a value and still have consequences for if they were misused, for example.
So we are talking about dangerous, addictive substances that have a market value.
When we're talking about
in one
the
of those
emergency
classes.
drug supply
Okay.
and the controls around the emergency drug supply, yes.
Okay. So back to management, where dangerous substances that have a market value, a danger to patients, a danger to staff, danger of theft. It's an inventory control issue, and I'm just looking at management's responses to the recommendations, Q2 2019, Q2 2019, Q1 2019, Q2 2018. It seems to me that it's, and I recognize the complexity and the layers of it, but can you assure the residents of the city of Ottawa who have parents, grandparents, brothers, sisters in our long-term care that you will give this inventory control issue the importance that it has, given the substance and the risk that we're dealing with?
Going back to the question about the different types of medication, the medication that goes into the sealed bins are over-the-counter medications, such as Tylenol, Imodium, those types of things. They should be removed from their packages, put in the bin, and with water added. The other medications go into a lock box with two authorized individuals that review that and track that, and then it goes into that lock box until returned. So there's quite a bit of rigor, I think, around the policies and the procedures currently. Certainly the Auditor General has pointed out some gaps and some areas where we can improve, and we take those seriously, and we will look at each and every one of them and implement them as soon as possible.
With respect to some of the procedures, let me bounce back to the Auditor General. Is it a question of the policies and procedures being adequate or not adequate, or is it following the existing policies and procedures?
Mr. Chair, as regards the emergency drug supply, which includes both controlled and non-controlled drugs, the policies are adequate. They are just not being followed.
Okay.
And that is where we are most concerned about the risk of diversion. It's in the emergency drug supply.
Okay. And I understand Janice, what you were saying about the controls that are in place. Let me ask you, on any given day, with respect to receiving drugs, on any given day, how many people are authorized to receive the drugs? And what I'm going to get to is the illegibility of signatures. How many people are authorized?
So these questions are very operational. I've asked Dean Lett, who's the Acting Director of Long-Term Care, to respond to the question about the frequency.
I apologize.
Could you please?
Mr. Chair, could you please repeat the question?
On any given day, how many people are authorized to receive the drugs? When we're receiving drugs, and one of the issues is that there's an illegibility of signatures.
In the homes, we have a service delivery model that supports RNs and RPNs on the day shift, and on the evening shift. The legislation requires that 24 hours a day there is a registered nurse in the home, and those individuals are licensed to receive and to administer medications.
Okay. So RNs are the ones.
Sorry, and RPNs as well.
Yeah, okay. And they have, and I'll just wrap up, Mr. Chair. I know that there are others who have questions. Have you found, Mr. Auditor General, that, in your opinion, the application of the policies and procedures which you say are appropriate are being enforced, are being exercised in compliance with the professional standards of that profession?
Mr. Chair, through you to the council, I wouldn't be able to comment on what is expected in the nursing profession, but the controls that we would expect to see over the commodity, medication as a commodity, when you consider the costs and the risks that are associated with medication. From our point of view, the system around medication, the policies and procedures are, for the most part, adequate. There are a couple of gaps that have to be addressed, but what we are most concerned about are the procedures that are not being followed, and there is no enforcement, and there's no checking up that is being done to ensure that those procedures are being followed, and there's no follow-up when somebody doesn't follow those procedures. And I'm most concerned about the emergency medication inventory.
Okay, thank you.
Okay, thank you, Vice Chair. Sure. Councillor Deans.
Thank you. I'm going to be a woman of few words today because I've lost my voice. But I requested this systems management audit because of a gentleman that came to see me, Mr. Hughes, as you will clearly recall, that was concerned about his mother receiving drugs in a timely fashion on a schedule. And I'm wondering, I didn't see any specific recommendations on that. So did you investigate the timelines upon which each resident is receiving their medication against their individual care plans?
Mr. Chair, the councillor, through you to the councillor is quite correct. I spoke to that individual at length, as you well know, and it was the concerns expressed by him and others that initially led to this investigation. And we looked at all aspects of the system, as is evidenced by the issues that we found. The difficulty, and I think you'll probably see some of our findings later that would likely address some of the issues that were raised by that gentleman and others that we spoke to, and that is in relation to the dispensing of medication at the appropriate time for the appropriate resident. And you'll see later that staff had expressed concerns about the activities that they have to do and in the time that's available to it. And it's clear that affects the timing of the delivery of the medication. What we were not able to determine adequately to the level that we do in an audit was if that is a large problem, but it's certainly something that I think should be looked at, and I believe falls under the domain of the running of the home itself. And I think the report that will be delivered to the committee afterwards will address some of those issues.
Thank you.
Thank you, Councillor Deans. Councillor Wilkinson.
Thank you, Mr. Chair. I recognize some of the issues that are coming up because I have to take medications too. It happens when we get older. The issue that I think you raised a point that turnover of staff could be an issue. And it's really, I think, there's a couple of things that make at the crux of this matter. First of all, a few years ago, I know we were forcing efficiencies on every department, including long-term care, and they had some reduction in their budgets because of that. And it seems to me that the efficiencies here are not saving time, but making better controls. Did you see any indication that the problem is really related to the fact, and you've mentioned it a bit, that they literally do not have the time sometimes to follow all of the instructions that are part of the protocol in order to actually get the basic work done there?
Certainly, Mr. Chair, that was a sentiment that was expressed to us by staff, and we'll talk about it shortly. But when we talk about the lack of enforcement of key steps in the system of control around medication, that enforcement would come from the supervisors and management. The checking from time to time. We're not. It's the checks that should be done to make sure that people are recording as they withdraw medications from an inventory, that it's for a valid patient, and that the mathematical calculation is accurate, and that the inventory that's on that is on hand is the right inventory. But generally, those are things that would not be done by on a regular basis by the staff who are dealing with the residents. They might be part of that process, but certainly the reconciliations of the checking of inventories in the emergency drug supply, that is something that would be done by someone outside of the daily dispensation.
So maybe that then should go to staff. As I really was interested in, I know because of turnover, there has to be ongoing training all of the time, because there's a lot of regulations with these homes that people have to be aware of, and not just the ones that have the right to sign things, but the other staff need to understand and to know who can do what as well. Just was wondering what's happening with the training program, doing it not just for the frontline workers, but also for the managers as supposed to be checking on this to ensure that they are fully aware. Because I think that you do get busy in your jobs. We find it even in our jobs. Then you put things aside because you're too busy to get to them. And I think that there's some sort of prioritization of things that needs to go on. And I just was wondering, we've only had these homes for about 6 or 7 years now, I guess, since they were taken over from the province, or the regulations changed anyway. So what do we have in place to do this? And do you have adequate budgets to actually implement all of these controls, and if not, how are you going to deal with that aspect? There's two questions there.
Mr. Chair, all of our staff upon hire are put through an orientation program that would support the practices and procedures relating to medication. In addition to that, every 4 years we go through Accreditation Canada, and in 2016, our medication review of 119 standards, we were 98% compliant with the accreditation standards for medication. In addition to that, we also do, through the Institute of Safe Medical Practices, we do a survey of all of our homes on an annual basis, and then those quality improvement opportunities are built into to our medication program.
Well, there's one thing to get an orientation when you start, but I've been through those with other groups, and you get bombarded with a lot of information before you've actually been in doing it. Do you have, like after a couple of months, it's really very useful to then have a review going over, because at that point they see things happening, they know how it works a lot better, and they can actually understand things better, because it tends to, you know what it's like when you're being trained. Sometimes you get so much coming you can't absorb it all, and you need to have that practical experience to pick it up. Is there some sort of, not every so years, but within a fairly reasonable length of time of starting, but not immediately?
Mr. Chair, we do have peer support within our registered nursing complement. So when a new nurse starts with us, we will buddy them up with another nurse. and they would be there to support one another. Often as well, on the day shift, we would have a registered practical nurse and an RN working together. So there's that support between the two in terms of ensuring the medication practices are being followed. I would like to add one other point in relation to the recommendations and the delay in some of the recommendations moving forward. We are in negotiations for a new resident care information system, which will be implemented in the fourth quarter of this year. As a second phase to that IT plan, we will be going forward with an electric medication administration record, which will address several of the recommendations that have come forward in today's audit.
So it's really what you're saying with the training, it's really on the job from the people already there, as opposed to having a general review, taking them out of the situation and going over to make sure they understand things.
Mr. Chair, we also work very closely with our pharmacy provider, who actually develops the policies and procedures in conjunction with us. And we will be working very closely with our pharmacy provider to address the areas that are being recommended. We take these very seriously, and we've already started to take actions in terms of the receipt of the medications. When they arrive in the homes, they're being put under lock and key immediately until a registered staff can pick up those medications and take them to their unit.
Would that person from the pharmacy then ensure that the person signing for them is one of the authorized people, and that the medication, I think it was said, was counted or checked at that time to see that it was what was ordered was what received? Because that was one of the issues that I think I just heard raised earlier. So I think that's where it has to happen.
Mr. Chair, the receipt of the medications, from a legal perspective, a receptionist can receive those medications if they provide their driver's license number. So that's within the legislation currently. Our practice is to work with the pharmacy provider, and what we're doing now is we are going to have the driver, when he arrives, we will notify the charge nurse in the building, and that driver will then deliver the medications to the charge nurse in the building, so that we won't have them being stored at the reception area until a registered staff member is able to pick them up.
It wasn't just picking them up, but that was also to check if the quantities received were what was on the list, basically.
So the receiving of the medications, for the nurse to go through all of those, it would be very time-consuming and would have a direct impact on the care and services to residents. We are doing the checking on the night shift, where there's time for the nurse to be able to validate the medications are correct, and any discrepancies are reported immediately to the pharmacy, and those discrepancies are corrected right away.
So you have that arrangement with the pharmacy. They take your word for it then. I know that's the problem, of course, that these are busy places with patients that need a lot of attention normally, and I can see where the difficulties could come in. So, but I do think the ongoing training is actually crucial, not just for the ones the city runs, but everyone in the province, frankly. So thank you.
Thank you, Councillor Wilkinson. Councillor DeRusse.
Thank you, Mr. Chair. I think Councillor Wilkinson asked lots of good questions, but it is really sad and disturbing to read some of the findings on the auditor report, because when people put their parents or loved one at home, it's the main thing is because for us to give them a long-term care, which is medications come first. And in the finding and all these this management receiving and dispersing and all that, I'm glad to hear management. Excuse me. I'm glad to hear the management are taking steps right away, and because these are very important key findings, and I hope we're not going to wait for another 2-3 months to do another follow-up. But I encourage the senior management to really look at this very seriously, because really the drugs are important for our residents. I sit on a board of the director for the long-term care in Osgood Care Center. Most of you know that. And our main and our stream, the most important thing is to look after the drugs, how we administrate the drugs, how we receive them, and how we dispose them. It's really sad to see that we had to wait for an auditor report to find these findings. So I hope that all these mistakes will be look seriously at them and don't wait in the time frame. We need to address them right away. My other question would be probably to the AG, that do we have a price tag about all these mismanagement Do we look at how much it's costing the city taxpayer, or is it in the thousands, is it in the million?
Mr. Chair, I can say that we did not cost out the potential losses if anything was if any medications were diverted, but and we did not cost what the extra controls would be. This was an investigation around medication management, and we've identified the problems, and the solution rests with management. But at the end of the day, the policies and procedures that have been written are, for the most part, adequate. The question is the enforcement to make sure that staff are doing what the policies and procedures say they should do.
Thank you, Mr. Chair. And I really address the senior management. I really think with the 17 recommendation, we should really look at them and try to address them one by one as soon as possible, because there is no room for mistakes when we administer drugs to our senior. Thank you.
Thank you, Councillor Cruz. Councillor Kader.
Thank you very much, Mr. Chair, and thank you very much, Mr. Hughes, for your audit this morning. Just a couple of things, Mr. Hughes. I mean, we've worked on audits from your office and on a previous auditor on a regular basis, and majority of the audits that I see sitting around this table seems to suggest a lack of check and balances. You mentioned this morning that you see the policies in place, yet it's not being followed, or there's a lack of follow-through. As an auditor, do you ever recommend to the city staff as to how to not only improve the checks and balances that are currently in place, but how to go beyond that step in terms of carrying forward to avoid audits like this, where, the biggest thing I see here is the lack of checks and balances. I mean, the policies are there, staff is there, yet there's no follow-up in terms of either receiving these drugs and or handing them off to an appropriate person and or to administer them properly. So just your comments on that, Mr. Auditor.
Mr. Chair, through you to the councillor, I think a prudent manager looks at all of the activities under their responsibility and identifies the areas of risk. And knowing where the areas of risk are, of course, in this instance, it's in patient care, and it would be in medication as well. And when you look at medication, where are the risks? And the risks are going to be things like over-medicating, under-medicating, not medicating, and then the control over the medication itself. And there was a time when somebody sat down and developed the policies and procedures that are in conformance with the legislation, and whether those policies and procedures were ever followed, we do not know. But we do know, for example, that the validation of the withdrawals and the verification of the inventories from time to time are not happening now. And the question that a prudent manager must ask is, where should I be ensuring that my staff are performing certain functions to protect the residents and to protect the organization and ensure that the organization is in compliance with the legislation? It's a question that a prudent manager on a regular basis must ask themselves.
So thank you for that. Just coming back again to that point, when you mentioned the manager or the supervisor on duty at that time should be, acting on those items, going, into making sure that their procedures are followed. Have you or your people, when you go and do those audits, ever recommended to the on-site staff at all about those suggestions or those comments that you have or that you're going to report on to say, look, here's something where it's lagging, so you must follow this, or you must follow that procedure, besides talking to the upper management? Obviously, you do that through the report.
Mr. Chair, when we go in, and I will tell you that I have visited the home as well, and I've seen how busy they are, and I've seen how dedicated their staff are. There's no question that the staff are not dedicated. I think everyone has commented on how busy they are. when we talk to the staff, we ask the staff to provide us with all of the policies and procedures and where they're located, for example. And we receive them from the staff and from management. So staff and management are aware they exist, and it's is it possible that that it's something that they haven't looked at in a while? I do not know, but that's the whole purpose of checking up and ensuring that people are following the procedures that have been laid out. And if you go back to someone and say, when you removed X from the emergency drug supply, you didn't say which patient it was for. That just the act of going back to that person, reminding them that they didn't put down the name of the resident that the medication was for, will reinforce the fact that there is a system checking up on what they're doing. And it's imperative that these activities happen, because it protects the commodity of the medication, and it reminds the staff that of the duties that they are supposed to do in case they've forgotten.
Thank you. Thank you, Mr. Chair.
Thank you, Councillor Kadri. Councillor Egli.
Thank you, Chair Huey, and thank you for letting me sit in this morning. I want to kind of take Councillor Derouse's question and turn it on its head. What you seem to be suggesting is that all the right steps are there. There's a few tweaks in terms of processes, but all the right steps are there. They're not necessarily being followed. And some of my colleagues talked about cameras a little while ago, and why don't we have cameras? So was a costing done of the necessary funding to implement the gaps or the tweaks or the cameras? Because it seems to me that's where the cost issue is, based on what you're saying. All the right pieces are there, they're just not being followed. And how do we follow them? And technology is one of the ways we can do it, through cameras and whatnot. So it could be yourself, it could be staff. Do we have an idea of what the dollar amount is that's necessary to meet the recommendations that you've suggested?
Mr. Chair, no, we did not do a costing, through you to the councillor, but cameras don't make sure people do what they're supposed to do. They provide another benefit. But I have come here in the past with audits where there are no policies and procedures, and our recommendation is to put policies and procedures in place. In this instance, there are policies and procedures that are, for the most part, as you put it, a little bit of tweaking would improve those policies and would improve those procedures. That tweaking should be done, but ensuring that people carry out the procedures is what, in my mind, is most important. What that would cost or what that would mean, that would be up to management to determine.
And I don't know, Janice, if you're in a position to answer. I know we're going to have a bigger discussion in a meeting that will come shortly thereafter. So I don't know if this is the right forum to have that discussion or not, or whether you want me to save that until the next committee.
There is Mr. Chair, there is a report that's going to FEDCO tomorrow, actually, and within that report there is a recommendation to establish $1 million to set aside for things such as technology, training, and some equipment that needs to be changed, such as beds and lists and those sorts of things. So out of that funding, it's something we can certainly look at, and that was what we identified in our recommendation back to the Auditor General about reviewing the costs and risks associated with putting the cameras into these rooms.
So I don't want to let it sit out there that I'm just concerned about cameras. Obviously, that's the more substantive piece, but one of the things that we seem to have heard is there should be more than one staff doing this, and there's only one staff doing it. This might be better done during the day, but we're doing it at night because it's less busy at night. So is some of the answer to this a change in how we staff or how many staff we have? Is that part of the solution that would make the existing policies and procedures work better?
So that is a twofold question, and just in terms of the front-end question, Mr. Chair, is that we have, through all of our consultations and through all of the reviews that we have, the one consistent message is that we need more staff. So absolutely, that will assist us going forward, and there will be more information coming forward at CPS following this meeting today. At this point, I'll just turn it over to Dean to talk a little bit about the staff that do, the authorized staff for medication.
Mr. Chair, so the staff that are authorized to receive and administer the medication are all licensed. So the registered nurse, registered practical nurses, they by law are bound to the policies and procedures relating to the administration of medication. The reconciliation of the medications on the night shift, we've not had any issues where a resident's health or safety was put at risk because we chose to do the cross-check of the medications on the night shift. So there hasn't been an identified risk associated with a resident not getting a medication because we delayed in checking the medications that come in.
Just a very quick follow-up for the auditor. I had thought during your presentation you indicated that was one of the things you thought needed to be addressed. Or am I missing something?
Mr. Chair, the reason why we raise it is the risk is not to the resident. The risk is that medication could go astray before it's reconciled. And well, it's wonderful that the pharmacy provider will make up any deficiencies. That just means that we have facilitated the possibility of medication going astray before we do the reconciliation. That's what the recommendation is directed at. It has nothing to do with residents missing medication. It has nothing to do with the city having to pay extra for medication that might go astray. It has everything to do with ensuring that medication is protected immediately, that it arrives in the home and reconciled right away, so that there is no possibility of diversion of that medication.
Okay. No, thank you for that clarification, because I think everybody around the table is concerned about the patient care and getting the right medications and getting them on time and in the right amounts and everything else. So that helps.
Thank you.
Thank you, Councillor Al-Sattari.
Thank you, Mr. Chair. And I still like to go back to what I heard from staff about their response to the cameras. So if there's a cameras in the hallway and camera system in the building, why this one to add it to the medicine room will take almost another year to get installed? I need to understand this, why, especially we heard tomorrow is going to be funding allocated to that area. So can somebody explain to me why it would have to take another year to have a camera in a medicine room?
So, Mr. Chair, we're going to move that action further and have the corporate security give us pricing to install those cameras. And as Janice mentioned earlier, we could be looking at taking out of the capital funding if it's approved tomorrow.
So you're telling me we don't have to wait till first quarter of 2019 to install cameras in the medicine room?
That's correct.
Okay, thank you.
Thank you, Councillor Al-Sattari. Just want to point something out. Like there's a lot of questions here, and we're just through the first part of the report. And I think it needs to be said that typically, Mr. Auditor General, you touched on it earlier, usually you come to committee with recommendations to enact a new policy or modify a policy. And often what we're dealing with here is finances and dollars and cent issues. This is different. This report today is about my parents in long-term care. It's about your parents that can go to long-term care or your grandparents. So we're actually dealing with people issues today. And so I really appreciate that my colleagues had a lot of questions on this report, because some of these findings were troubling. I think it's great to see that management recognizes what needed to be done here and has a path forward. There's questions, and this is where I'll put my question in. I just don't understand when it's something as simple as we can't read the signature, that something can't be done right away to address that? Can employees not be given a number that they would sign with that number that you could recognize? Or could you ask them to print their last name so that you would know who's touching that medication? Why can't something like that be done right away instead of waiting for an IT system sometime next year?
So, Mr. Chair, the medication administration record, the forms that are being used and provided by the pharmacy are standard for our industry. They are very tiny in terms of where a staff member can put their initials. That's why we have a master list of all of the employees who are licensed to provide medications with their initials, their signature, their employee number, so that we can have an independent review to validate who has administered those medications.
Okay, then follow-up question to the Auditor General. Were you provided with that list when you were there so that you could reconcile who signed on the medicine? Or?
Mr. Chair, we were provided with that master list, and we were not able to reconcile the signature in the MAR, or the medical record, with the signature in the master list of signatures.
Thank you. So back to management, I think there's still an issue here. You've got to figure out a way that you can have inventory control over this medication in a way that someone else can read and know who signed out that medication.
Mr. Chair, I should also point out that in some instances, the master list of signatures has exactly that, signatures, and yet in the medical record they're showing an initials. So you can't, even when you do have a complete list of signatures, if somebody's using their initials, they're still illegible.
Okay, thank you, Mr. Auditor General. I think what we'll do here, I'd like to move on to the second part of your report. Perhaps, Vice Chair, we'll have one last question. I'd like to offer to or ask the Chair Deans to perhaps take that on with her committee to try to figure out a way that they can track the medication, that you yourself would be able to know who signed it. Is that fair? Thank you. Okay, Vice Chair.
Just two quick, one comment and one more question. So let's remember, the objective is not to the signatures. The objective is to have control on the supply of drugs. That's the objective. So that there is a master list, but that it's not being reconciled does not attain the objective. On April 13th, we received a follow-up from Kevin Wiley and from Dan Cheney with respect to two audits that this committee had undertaken, that the Auditor General had undertaken in November, giving us an update. Can I ask management whether in 4 months we could get an update as to the recommendations of the implementation of the recommendations that we are finding in the Auditor General's report today in 4 or 5 months, as other departments have done?
Mr. Chair, absolutely. As we have been keeping folks apprised, the stakeholders and council, in terms of what's been transpiring for the last 9 months, we continue to send updates and work plans and compliance plans. We will send out any information as updates.
We'll get that in the fall?
Absolutely. We can start it by the fall. Thank you.
Chair.
Mr. Auditor General, would you like to start your second part? And after this presentation, we're going to go to Mr. Kanellakis for a comment from the City Manager's Office, and then we'll deal with questions on the second part of the report. So members, let me know if you have any questions. Go ahead.
Vers la fin de l'année passée, le Bureau du vérificateur général a reçu 2 lettres anonymes présentant des allégations de pratiques de gestion douteuses relativement à un incident de violence sexuelle entre 2 résidents qui aurait lieu d'un de nos foyers. Nous avons entamé les travaux aussi vite que possible et pour assurer l'intégrité de l'information, nous avons intégré l'enquête à l'examen de la gestion à l'examen de la gestion des médicaments. Le but de l'enquête était soit d'informer, soit de confirmer les allégations présentées dans les lettres concernant les actions de l'administration. L'enquête portait sur les faits entourant les mesures prises par l'administration en réponse à l'incident. Des entrevues ont été menées auprès des employés actuels et d'anciens employés du foyer. Nous avons étudié aussi la législation et aussi les règlements, ainsi que les politiques et procédures de la Ville concernant les rapports d'incidents et la violence sexuelle. Nous avons aussi analysé les dossiers médicaux des résidents impliqués, les rapports de corps, les journaux du personnel de garde, les rapports d'incidents internes et aussi externes, les rapports d'inspection du ministère et les courriels des employés. Late last year, the Office of the Auditor General received 2 anonymous letters regarding allegations of questionable management practices in response to an incident of alleged resident-to-resident sexual abuse at a City of Ottawa long-term care home. We began our work as quickly as possible, and to ensure the integrity of the evidence, we incorporated this work with the medication management review that we just presented. The information we received purported that management did not respond to the incident appropriately. The objective of our investigation was to refute or validate the allegations and concerns raised in the letters in relation to management's actions. We gathered evidence in relation to management's response to the incident to determine whether they complied with the Long-Term Care Homes Act, the respective regulation, and the city's policies and procedures. In the course of this investigation, we conducted interviews with certain current and former staff members of the home. Accordingly, we interviewed the registered nurse, the registered professional nurse, and the personal support workers, both those on shift and those on subsequent shifts, the on-call manager, the program manager of resident care, and the program manager of personal care. We reviewed the legislation, of course, the Long-Term Care Homes Act and the regulation, and the city's policies and procedures related to incident reporting and sexual abuse. We examined the health records for residents involved, the shift reports, the on-call logs, the incident reports, both internal and external, the ministry inspection reports, and selected employee emails. Once again, I have to state that staff were open and cooperative. Now, I must say that some of what you will hear will be disturbing, and I apologize, but this level of detail is important to understand both the incident and the problems that we've identified with the response to the incident. Au printemps 2016, un résident a emmené à sa chambre une résidente atteinte de démence confinée à un fauteuil roulant. Le résident avait manifesté un comportement sexuel inapproprié à 2 reprises pendant la journée et le personnel l'avait consigné. En entrant dans la chambre, l'employé a découvert le résident complètement nu, essayant de se positionner sur la résidente, complètement vêtue et assise dans son fauteuil roulant. L'infirmière agréée a communiqué avec le gestionnaire de garde pour l'informer de l'incident et savoir si le cas devait être signalé à la police.
On an evening shift last year at a long-term care home, a full-time personal support worker, I'll refer to this individual as the lead PSW, was working on the floor that night with a casual PSW. And a casual worker is someone who's not a full-time employee, and they fill in for the permanent full-time staff. They were working on the transfer of residents to the rooms that takes place after supper. The lead PSW was checking both sides of the house because the casual worker didn't know where to put the residents. During this time, the lead PSW asked the casual PSW about a female resident they didn't see because it was time to put the residents to bed. The lead PSW went to check for her, and he didn't find her. The female resident is confined to a wheelchair, and she is nonverbal. At that point, the lead PSW ran to one of the male residents' rooms because they had a feeling. The lead PSW stated that they had been briefed about a male resident exhibiting sexual behaviors when they had started working on that floor. On 2 separate occasions earlier that same day, the male resident had been reported to be demonstrating inappropriate sexual behaviors We verified that this was documented by staff. The lead PSW entered the male resident's room and witnessed the male resident fully undressed, trying to position himself on the female resident in her wheelchair, who was fully clothed. The lead PSW observed that although the doors are always open, this time it was closed. The room was dark. The washroom door was closed. It's usually open. The blinds were drawn. The curtain inside the room was closed, and the female resident was positioned in the corner. The lead PSW immediately contacted the casual PSW for assistance and instructed his coworker to get the RPN on staff. The PSW instructed the male resident to put on his clothes and stayed with the residents in the room. The RPN attended to the scene of the incident and then left to notify the RN, the charge nurse on duty. While the lead PSW and the RPN were in the male resident's room, the male resident made sexual comments and demonstrated sexual behaviors. The charge nurse attended to the male resident's room and was provided with full information as to the details of the incident by the PSW and the RPN. The details of the incident we reviewed were recorded in detail in the progress notes in GoldCare. And GoldCare is the information system used by staff to record all resident information. The charge nurse contacted the on-call manager to advise of the incident and to confirm whether the incident should be reported to police in the ministry. The RN and the on-call manager agreed that based on the facts of the incident, it did not meet the criteria for sexual abuse, and therefore the police and the ministry need not be notified. This decision was based on the fact that no physical touching was observed, and the RN's assessment did not identify apparent injury to the female resident. At that time, one-on-one care was assigned to the male resident. The next morning, shift change, a new charge nurse comes on duty. She becomes aware of the details surrounding the incident. Through her review of the progress notes, she has concerns that the ministry and the police were not notified. She contacts the on-call manager, the same on-call manager from the night before, and provides the details of the incident. Based on this information, they both agree that the police and the ministry should be notified immediately. The ministry is contacted by phone to report the incident, and the incident is reported to the Ottawa Police. A day later, a critical incident report is submitted to the ministry. With respect to our findings from our investigation, the first aspect of concern is that when we reviewed the policies and procedures that the cities have, when we reviewed the legislation from the Long-Term Care Home Act, we found there were inconsistencies with respect to the guidance for external reporting of incidents of this nature. So we created this table, and I apologize, it's not easy to read, and that's part of the issue. On the first column, you'll see the city's policy on the critical incident system, and this is essentially a policy on reporting requirements. In the second column, it's the abuse policy in the city, and then in the third column, the long-term care home regulation. And we just took small aspects of these that demonstrate where the inconsistencies and the confusion is. In the first column, you'll see that it talks about when to notify for an incident of abuse. The first one mentions injury, that there must be injury for reporting. The second two, the policy and the regulation, do not mention injury. In the second row, there's guidance for calling the police. Again, the first column indicates injury, but neither the abuse policy nor the regulation mention injury as a requirement for immediate reporting. Finally, in the last row, specifically relating to a single policy, the reporting policy, in one section it states, all alleged, suspected, or witnessed incidents of abuse will be reported to police. In another area of that same policy, again, it mentions injury in relation to abuse. So as you can see, it's difficult to understand the guidance, and this causes a problem for staff. As stated earlier, staff did not immediately report the incident to the ministry and the police based on our understanding the facts of the incident, immediate reporting should have taken place. Notification was done the following day. This action was in response to the second charge nurse that came on duty the next morning, inquiring and following up on the matter with the call manager. Had this person come in and not revisited the decision that was made the night before, this incident would have gone unreported to both the ministry and police. The requirements for identifying and reporting abuse did not seem to be well understood by frontline staff, and this increases the risk of noncompliance. It also indicates that there is no assurance that a similar incident occurring after this would have resulted in proper notification to the ministry and police. We also found that there was discrepancies in the recollection of the communication that took place on that evening. We examined the communication and the accompanying documentation between the RN, the charge nurse on duty, and the on-call manager on that shift. We found differences in this information. In our interview, the charge nurse recalls that certain detailed information was provided to the on-call manager. We noted that her description of the incident, as well as the reporting in the system, was consistent. It was also consistent with information that we obtained from other staff in our interviews. In our interview with the on-call manager, it was stated that these additional details were not provided or reported on the night of the incident. It was stated that had these details been provided, this would have changed his determination that the incident would meet the definition of sexual abuse, which was done the next day when the purported additional details were reported by the charge nurse the following morning. On-call managers maintain a log of information, so every time they receive a call, they're to document the details of that information. We found that the details that were recorded by the charge nurse in the system that night were not consistent with what was reported in the on-call log. There was much less information in that log. Furthermore, despite the on-call manager's belief that they received inadequate information to make an informed decision, there was no follow-up conducted by that manager with the nurse regarding this matter. It would have been a good practice to prevent reoccurrence and ensure future compliance with reporting requirements. With respect to measures to prevent the incident, based on the information we obtained in interviews and the content of progress notes, the documentation that staff does, the male resident was identified as a potential sexual abuse risk. Based on our interviews with staff, the unit where the male resident resided consisted mainly of female residents who do not have the mental capacity to have a consensual relationship. The notes reflect that the male resident was exhibiting inappropriate sexual behaviors on the date of the incident, and administered medication was ineffective. Based on these facts, in the absence of close supervision, the male resident posed a known risk to the other residents of the unit. Stronger safety measures were only implemented after the incident occurred, and this was in the form of providing one-on-one monitoring of the resident, and eventually the resident was transferred to an all-male unit in the home. Had these measures been implemented earlier, the incident may have been prevented. Number 5, we spoke to a number of staff, and in the course of our interviews, there was a recurring concern that we heard, that the amount of staff was just not conducive to the work demands, and it was resulting in burnout, in absenteeism, and in staff not consistently following protocols. They gave examples to us of where staff did not follow procedures when operating lift systems, medications being administered outside of prescribed timeframes, and staff not reporting incidents occurring close to shift change, as it may result in overtime that might not be approved.
Excuse me, Mr. Chair. Another finding was that the perception of staff is that management at the home does not consistently respond to concerns on a timely basis. During our investigation, we conducted several interviews with staff who held different roles within the home on or around the time of the incident. A recurring issue noted by the interviewees is that there's a perception that management does not always respond to concerns on a timely basis. In some instances, staff had the impression that there's a lack of follow-through and action in relation to developing a management plan to issues addressed at this home. We also found a lack of awareness of the fraud and waste hotline. The city's employee code of conduct requires employees to disclose breaches of the code of conduct or other city policies. The matter can be reported to their manager, the city solicitor, the city manager, or the auditor general. A majority of the interviewees were not aware of the auditor general's hotline. Employees who were aware did not know that it could be used to report concerns with respect to non-compliance of the city's practices or non-financial questions or non-financial questionable matters. In interviews, some employees said they may have reported concerns anonymously through the hotline. For the most part, staff we spoke to felt comfortable raising issues with the direct supervisors about workplace issues, although there is a reluctance to raise concerns they may have had about their own managers. Now, Mr. Chair, I must say there's been much discussion at previous audit committees about the need to revitalize the fraud and waste hotline, the need to promote the hotline, looking at the name of the fraud and waste hotline and better definition of issues that are reported. And I can say that the city manager and I met as recently as last week and have committed to put together a plan to address the issues that were brought up in relation to the fraud and waste hotline. During our investigation, we identified over 200 relevant, and when I say relevant, they actually talk about this particular incident, 200 relevant emails, but there may have been more. But unfortunately, we were only able to obtain 22 of these. Backup emails are overwritten every 3 months, which limits our ability to recover possible evidence related to any matters under investigation. Without sufficient evidence, the city may not be able to take the appropriate actions, including pursuing or seeking recoveries to protect the city's incidents. A recovery rate of only 10% was quite disturbing on our part. En conclusion, ce n'est pas possible d'assurer qu'avec un incident semblable à l'avenir, que la gestion protégeait les résidents et respectait la législation. In conclusion, Mr. Chair, no assurance, we have absolutely no assurance that should a similar incident occur in the future, that it would be handled appropriately to protect the resident and comply with the legislation. And that concludes our presentation, Mr. Chair.
Thank you very much, Mr. Auditor General. Mr. Kanellakis, would you like to address the reports?
Well, Mr. Chair, thank you, and thank you to the Auditor General for his findings and his work on these two files. The only comment I'll make is that, and I realize there'll be questions on this incident which will flush this one out more fully. The few comments I want to make is that long-term care, because of the issues here and as we're seeing provincially and nationally, is under a great deal of scrutiny. Mr. Fougere will be here at CPS committee later this morning as an independent third-party review. The Auditor General has just conducted 2 investigations as a result of fraud and waste hotlines. The Ministry of Health and Long-Term Care has been in the homes. In fact, they were all 3 in the homes at the same time. We have a multitude of recommendations that we've received from the auditor, from Mr. Fougere, which you'll see, and from the ministry, which have been incorporated into a comprehensive action plan that is going to be actioned, and people are going to be assigned to action these things. Some of the timelines, I know council members have raised the timelines. Some of the timelines were actually stayed as they were because the audit recommendations were done before we have the action plan completed. around the finances and some of the other recommendations and motions which will be presented at the CPS committee and at FEDCO. So there's been ongoing developments as this has been going in terms of improving and making creating the implementation, the momentum to correct these actions. You will see that, and the auditor has acknowledged this, that staffing is a significant issue in terms of the ability of our staff to be able to complete all the expectations that we have on them. I personally have met with over 20 supervisors in a group from long-term care, from all the homes, from nurses to personal support workers to people working in the kitchen to maintenance people. And the number one issue they do have is the amount of time in a day to be able to complete their duties and their responsibilities to the fullest and to their responsibilities to be able to care for the residents. They all state that their number one priority is resident care and taking care of their residents, and they feel very stretched in their ability to do it. And this is something that I think that we're going to be able to address with a very aggressive plan that will be coming forward later this morning that management is endorsing. As far as the incidents, the medication management, the abuse incident, I think the Auditor General has done and through the questions and answers, certainly in the first one, I think you flushed out the key issues around this. I want to say that the potential on the medication management of something going missing and something happening is there because of the gaps. However, the findings didn't show that anything actually went missing. We don't know that they did or not, and that's part of the problem, and I think we have to tighten that up. But I want to assure Council also that the Auditor General also found that the drugs administered do correspond to prescriptions, the people's prescriptions. And sometimes mistakes do happen. They happen in hospitals, they happen in long-term cares. And I'm not trying to excuse it, but I think that the findings here and the recommendations are very good for us in terms of tightening those things up and ensuring that we don't have any ability to create a perception that these things aren't happening. The abuse incident, I know you're going to hear more about what happened on this one. It's heartbreaking to hear that this incident has happened. It's heartbreaking to hear, and you will hear from Mr. Frugere, that patient-to-patient abuse is something that does occur in long-term care homes, not only in the Ottawa homes, but private sector homes and other nonprofit homes. It's an unfortunate reality when people have lost their mental capacity and diminished mental capacity due to dementia and Alzheimer's and a variation. And I think it's one of those responsibilities that our staff have been taking, that also they expressed in the meeting to me about the challenges of dealing with a different kind of patient than when they started 20 and 30 years ago. They're seeing the incidence now of managing the complexity of their case files has grown significantly when a lot of them started years ago. But that doesn't excuse the fact that we have to have policies and processes in place, that we have to report when we know. Do human communication issues happen along the way, and someone doesn't follow a policy or doesn't think that the situation applies? Absolutely, and I think the auditor has done a good job in terms of identifying the discrepancy between our policies and the Ministry of Long-Term Care policies, which should tighten up that process so something like this doesn't fall through in terms of interpretation of what actually occurred. So thank you to the auditor, and I turn it back to you, Mr. Chair.
Thank you, Mr. Kanalakis. Councillor Minette.
Thank you, Mr. Chair. I guess some of the things we're hearing, especially the second part of the report, is quite disturbing. A report of abuse to police and MOHLTC. Did the city have a procedure in place for the reporting of abuse?
Mr. Chair, through you to the councillor, yes, the city did have a procedure in place, and we pointed out that there was a discrepancy between, in one policy, there was a discrepancy within the policy Then there was a discrepancy between two policies, and they were at odds with the legislation. And it's that type of confusion that has to be eliminated to make it very, very clear for the frontline staff and the on-call manager when they're making these decisions when an incident happens. Sometimes in the middle of the night, sometimes when they're on call, they're in the middle of other activities and they get called away to make a decision. And the policies and procedures should be clear, and that's where we pointed out the discrepancies.
I guess, not reporting, especially the abuse to the police and Ministry of Health Long-Term Care, I guess it's disturbing. What actions were taken for non-action of reporting? Because basically in the report here it says that anytime there's abuse, then it should be reported to police and Ministry of Health and Long-Term Care. Was any employee reprimanded because of non-action?
Mr. Chair, I'd have to turn that over to City Manager to respond.
Actually, Mr. O'Connor, do we have to go on camera for that?
At that high-level question, no, Mr. Chair, but I would encourage members to refrain from going down the path of further labor relations issues. Okay.
So when the event took place, both families were notified on that very same day. The information that the on-call manager received was such that the decision was made that this did not constitute sexual abuse, and therefore the reporting was not required. The next day, when additional information was received, the decision was made to contact the ministry and the police immediately the next morning. The ministry did complete their investigation, and in the end there was no findings of failure to report or no findings of failure to protect the resident.
I guess we're dealing with two issues. There's one issue where the patient was physically attacked, which everybody was aware of, and then there's another one with the sexual abuse. When you did your investigation, I noticed you spoke to staff. Did you talk to residents at the seniors' place also?
Mr. Chair, through to the Councillor, we didn't speak to residents, but we spoke to a broad variety of staff in relation to that investigation.
Should that maybe not be something in the future when there is abuse reports to check with other residents, see if they're facing a similar type of abuse or have been made aware of from other residents about similar type of abuse? Many residents, especially seniors, might be a bit scared to come forward, but if they are approached with what has happened, it might be a good idea to get their views on it to see if it's widespread or if it was just one incident.
Mr. Chair, that's something that we hadn't considered. I guess I'll take that under advisement and have discussions with staff, but I'm certainly not aware of requirements under the Act beyond what was done by the city staff in relation to this incident.
In some instances, we're seeing that staff felt had the impression that there was not enough follow-through from management in implementing action plans and addressing identified issues in the home. I know we have the hotline, but in cases like this, where they're actually critical cases, we're dealing with abuse, physical abuse and sexual abuse. Is there a mechanism where staff could contact someone without having fear of reprisal from management that they have taken that action?
Mr. Chair, I think the hotline is it's been operating for well in excess of a decade. It has respectfully handled the issues that have been identified to it. It has reported out. It has protected the anonymity of the individuals who provide the reports. But as was identified in this investigation, we have to do a better job of promoting it. And I can say that the city manager and I, when we met, discussed at opportunities that we could address those issues, and we'll probably be coming back to the committee with an update on what our plans are in that regard.
One thing that was quite disturbing is that both incidences, they've identified that staff, frontline staff, which did a fantastic job. They brought it up right away. They brought up that police should be notified, and it was decided by I guess senior management at the time, at the residence, that no, it was not required. Waited till the next day, then they decided, okay, well, maybe we should report it to police. Could we not look at a procedure in the future that if any staff suggests that police should be notified, that could not be questioned and that action is taken immediately to contact the police?
Mr. Chair, I think the issue was the contradictions that we saw, that were identified in the policies. And we were told that the discussion with the on-call manager centered around whether or not there was an injury to the other resident. And it was the focus, and that's the problem with that we identified in the policies. By focusing on the injury, the decision was made, and there was no physical injury, there were no wounds, no obvious physical wounds. By focusing on the injury, they made the wrong decision to not report to the police and not report to the ministry. And it was that follow-up the next day with other staff that questioned that decision that led to the right decision. And I believe, and that's why we recommended that if you remove that contradiction and make sure that the policies align with each other and that the policies align with the legislation, and then you make sure that this is communicated to staff, then even in the heat of the moment, when these incidents occur, when staff go to look at a policy and a procedure, they will make the right decision because the right information is there.
Yeah, I still go back to, if staff has any perception that they feel that it shouldn't be reported to police, I don't think we should be questioning it. I think we should be acting on it immediately. And that's a suggestion I'm making right now to the city manager as we move forward. You have to look at that poor woman who was in that situation, having to go overnight, having to deal with that. I think the proper thing would have been, I don't care what the policy states about injury or whatever, if there's perception by staff that, and it is brought forward to management that they should call the police, I think that action should be taken immediately.
Mr. Chair, would you mind if I asked Janice and Dean to question this, because I think that's the councillors actually raised the issue. What did the staff actually tell the on-call manager about calling the police? And I'm not sure that was the recommendation of the staff. So maybe we can just get clarification about what did the on-call manager actually hear from the staff, which caused the confusion, I'd say, or the delay in the reporting.
So just in terms of some context, Mr. Chair, the event did occur 1 year ago, over 1 year ago, and since that time there's been extensive training around failure, the need to report, and abuse and neglect. And so so there was no discussion at that point about calling the police on behalf of the original nurse. The information that was provided in Gold Care, that's where the documentation is. And what we have, what we're proceeding with is so that all on-call managers sees all the information in Gold Care to assist them in making a decision versus just what has been communicated over the telephone. So that should alleviate that contradiction or that discrepancy in terms of the conversation. I can tell you that since this incident and the Auditor General's report, the policy has been changed there so that it does absolutely align with the ministry, and that extensive face-to-face training has occurred in all of the homes. We will be having awareness weeks every single week in the home, and we have posters and cards distributed to all staff to ensure that their responsibilities are clear around reporting. And I just want to turn it over to Dean to talk about what some of the options that do exist for staff who perhaps want to disclose certain information.
Mr. Chair, as indicated earlier, there is a toll-free number that any person can call, staff members, families, residents, visitors, members of the general public, if they have any alleged or suspected abuse or neglect that they want to report. And staff are encouraged to do that. Staff are also, when they've witnessed an incident, they are involved in the reporting. So the electronic submission of the critical incident to the ministry is supported by the individual that witnessed the event. I'm just going to add a couple more things in terms of the training that we've done since the event that took place last summer. We've done 100% training with over 1,000 employees on the prevention of abuse. We have a zero tolerance of abuse or neglect in our homes, and we enforce that policy. We conducted testing on all of our staff, and for those staff who did not achieve 100% on the test, we're given one-on-one coaching in the areas that they weren't sure in relation to the policies and procedures around abuse. As Janice said, we are putting an awareness week in place in the homes in June for all 4 homes. And that awareness is not just for our staff, but it's for our families, our residents, and our volunteers. The abuse policy is reviewed annually or as needed. And in some cases, if a ministry comes in and identifies an area in our policy where there may be an opportunity to improve, those improvements are put in place right away. And as Janice said, we have posters in the homes. We have wallet cards that people wear with their lanyards. And it basically says, if you see something, you hear something, say something. And that's a training that we've provided to all of our staff. And all of this training around abuse on an annual basis is being delivered in person.
Thank you, Mr. Chair. Just, I guess, one follow-up. I thank you for the proactive approach. I think it's something that's needed. I guess in closing, if an employee does see a scenario where he feels or she feels that police should be notified, is that the policy that they will notify the police immediately?
Mr. Chair, our policy does point to both contacting the Ministry of Health, to the director, and to the police to report. And the investigations then get conducted by those 2 bodies.
So it would not be questioned. Thank you very much. Thank you, Mr.
Thank you, Councilman. Councilor Alcantara.
Well, I think that was going to be my question about the police, and I think Councilor Manette did a good job asking those questions. So I'll stand down, Mr. Chair. That's somebody.
Good. Thank you. Councilor Wilkinson.
Thank you, Mr. Chair. I thank the staff for what they're doing. I think they've done a great job in moving forward because of the recommendation that you had, and I know there'll be more coming up in the meeting later on. There's a couple of questions I have more about. First of all, about staff. I know a lot of people have people in long-term care because at my age I have a lot of friends who have spouses and things there, so I hear quite a bit of things about it. And they're not necessarily our homes or anyone. But one of the things that I have heard about people who work there, that the staff themselves are often abused by the patients and often even hit and do. And I'm just wondering, what is our policy for dealing with situations when a staff is actually becoming physically abused by a patient? Because these patients with dementia and things often don't know what they're doing, and it can be quite severe. I haven't heard it talked about. We talk about the patient, but it goes the other way as well.
Mr. Chair, I'd just like to highlight the demographics of the clients that we're serving. 40% of our residents exhibit moderate to severe aggression. That can be yelling, swearing, punching, hitting, spitting. These are the types of things that our staff are subjected to. We have supports for our staff. We work very closely with the Royal Ottawa Outreach Team around de-escalation of behaviors and working with them and also providing the training to our staff in order to be able to do so in a safe manner. As a last resort, if we have a resident who we are not able to manage in the home, we would send them out to hospital until their care plan was stabilized and we can bring them back into the home. In addition to that, in each one of our homes, we have PSW behavioral support champions that are available as well to support staff in developing the appropriate care plan to provide care in a safe manner.
If a patient has a lot of aggression like that, I know this happens, do you have them go in pairs sometimes? I think some of our staff are actually at risk.
Mr. Chair, that's absolutely true. Some of our residents require two-person assist with the activities of daily living, and that's often for the safety of the residents and the staff.
Okay. And I think this also outlines the issue about how we're staffing our facilities now. They have, as you mentioned, changed drastically in the last 25 years. They used to be acting more like our retirement homes act now. They're no longer that way. They now have, the average age is usually over 90, and the level of dementia has increased significantly. And it's sad to see, but I think it does require, as a community, that we actually put the resources in place. And I'm hoping the committee, I'm sure there'll be some recommendations on that going to committee, but I think that's one of the things we do have to address. And I think that helps us in the prevention. The other one that I would like to ask about was, you mentioned that this particular case, they moved him to a male one. And I was wondering why he was in the female one to start with. Or do you not have an idea, unless it's a couple where you want them close together, that they actually separate the sexes? Because I think this kind of...
Sorry, Councillor Wilkinson, can we come back to the report?
Yeah, well, it was mentioned by the Auditor General. Yeah. That's why on this particular case, they moved him sometime later to the male section of the building as away from where a lot of women were around. I'm just wondering why that was not done even earlier if he'd been exhibiting features, but even why it isn't done generally in any case, because these kind of things can happen when you have them close together. We all know that. Yes.
Mr. Chair, we do move residents around when they're not appropriate for a specific area. In one of our homes, we do have a designated male unit where residents of the nature that was described in this incident would be placed for everyone's safety. However, the homes are full, and in order to move somebody, we need to make sure that we have an empty bed to be able to move them to another room.
So that's another situation that we have with they're always full. Okay, thank you. I appreciate that, but I think we have to look at that aspect a bit more in maps and designing and laying out our buildings. Thank you, Mr. Chair.
Thank you. Councillor Wilkins. Councillor Cloutier.
Merci, Monsieur le Président. Monsieur le vérificateur général, dans votre vérification, est-ce que vous avez observé des incidents similaires dans d'autres foyers de long terme?
Mr. Chair, we didn't observe any similar incidents. We were told of at least one and possibly a second.
And was it reported appropriately?
We're not aware.
You're not aware. Okay. I want to focus on page 22 of the report and a comment by Ms. Brennan with respect to the person had exhibited behavior earlier in the day that caused concern to staff. I guess my question is, what are the procedures that are in place with respect to a person who exhibits that, short of moving them to another unit, and were those procedures followed? And Ms. perhaps...
Mr. Chair, as I said earlier, we work very closely with the Royal Ottawa. When we have residents with aggressive behaviors, we would often have what's referred to as a PRN, which is per resident needs, and that would be an intervention we would use if we were dealing with an aggressive resident and we were trying to control them for their safety and the safety of other residents. We would look to give them a medication. We also have physicians on call 24 hours a day, so our nursing staff has access to call a physician if they need to get a medication immediately.
Okay. So were the procedures followed?
Yes, they were.
They were. So what actions were taken with respect to this resident?
So, Mr. Chair, this particular resident was provided with medication. It was effective for a period of time. The resident was being monitored. Unfortunately, an incident did occur that resulted in us placing that resident on one-on-one care. So he had a specific staff member assigned to him to ensure that no further incidents would occur.
But only after the incident. So he had exhibited aggressive behavior or inappropriate behavior, I believe the report says, earlier in the day. Medication was administered. There was no one-on-one at that time, was there?
Mr. Chair, that's correct.
And the incident did occur?
Yes.
Are policies being reviewed with respect to how effective they were in this instance?
Mr. Chair, staff are being educated that if they witness an incident of aggression with a resident, it be reported immediately. And if there is an immediate danger, we can apply for one-on-one staffing, and that's covered through the ministry's high-intensity needs. So that's the direction we would provide to staff if they had an individual who we were not able to keep safe, and then we would look at potentially moving them to the hospital if the behavior continued and we were not able to control it.
Okay. Mr. Leck, you referred to a toll-free number that staff can call. Where does that toll-free number go?
Mr. Chair, in the homes there are posters within the resident common areas and staff areas where the toll-free number is highlighted on that poster.
Who answers the toll-free number? What is the report?
Mr. Chair, the toll-free number is monitored by the Ministry of Health and Long-Term Care staff.
It's the provincial, okay. From a control point of view, there's a bit of a discrepancy between what the reporting nurse says, she said to the on-call manager and that person's interpretation of the fact. And from a control point of view, is there any way that we can improve the reconciling of those two differing accounts? Because it appears that only after the fact, the next day, the second RN escalated the situation.
Mr. Chair, we are currently in the process of developing a reference document with standardized intake questions so that we're asking the right questions when an incident is being reported. In addition to that, today our managers have access to the healthcare records of the residents that reside in that specific home. We're now working with our software to enable our managers to have access to all resident charts across the 4 homes so they can go in and read progress notes relating to any incident that may have occurred.
Are you referring to Gold Care?
Yes.
And on-call managers did not have access to Gold Care before?
That's correct.
And now they do?
They're going to be given that access. We're in the process of putting that in place. As I said, they have access to their own residents within the specific home they work in, and we're going to open it so they have access to all over 700 healthcare records.
And in this case, does Gold Care, and maybe this is for the Auditor General, does Gold Care reflect accurately the incident as opposed to the recollection of the verbal conversation?
Mr. Chair, the recollection of the nurse was the same as what was the same as the incident that was reported by the other observers. It was the same as the information in Gold Care. The only thing that differed was the recollection of the on-call manager and the notes that on-call manager made in the on-call report.
And the notes that on-call manager made in the on-call report are not the same as what we find in Gold Care?
That's correct.
And you had access to that call log?
We had access to everything, yes.
But no recordings? There are no recordings?
No.
Thank you.
Thank you, Councillor Cloutier. No other questions. I'll just ask a couple of my own here. I think this report goes to why many of us get involved in public service and employees as well, because we want to be there to help people when they need our help. And what this report highlights is where the system, I don't know if we want to call it broke down, but it certainly let down the resident involved in this. So my question to Ms. Morel is, if you're telling them to call this provincial toll-free number, in my mind that would not have helped in this case, because the provincial policy says there has to be an injury. Yet in our workplace, there doesn't have to be an injury. If someone's harassing you, or especially in this scenario here, if they've taken you in a room and gave every indication they're preparing to have sex with you, I think we would react a whole lot different. We wouldn't be waiting for the actual injury or even the touch. Just the whole suggestion of that would trigger quite a reaction, I would think, here at the city. So why would we want to suggest that they call the provincial number if that's not going to help?
So, Mr. Chair, I think you may be confusing the two. So the requirement that they contact the ministry is in the case of abuse, alleged or actual abuse that's witnessed. Mm-hmm. So, and that includes contacting the police as well. So that's the one option, and that's where the auditor had adequately pointed out that there was a discrepancy between the policy and the practice of the city. So that's since been resolved. The other hotline is an opportunity for any staff that has issues or concerns, and that includes families and volunteers as well, that may want to call and report something other than that duty to report to the ministry on instances of abuse or neglect. So those are two different requirements.
So separate and formal reporting, there's still the formal piece that goes. Okay.
And a hotline, yes.
Have we asked the province to change that policy, to take out the word injury, or change it to something more appropriate?
So, Mr. Chair, the incidents of injury are related to physical assault between two residents, and the definition within the ministry states that if there's no injury, you're to continue and put in place the appropriate actions to protect those residents. But if there's no injury documented, the legislation today reads that it does not need to be reported to the ministry.
Okay. And you mentioned earlier that the staff were aware that there was issues with this gentleman, but the all-men's ward did not have a bed available. Is that correct? And that's how he ended up in this ward as compared to any other ward?
Mr. Chair, no, I was implying that if we were to move that resident that night, we didn't have another vacant room in the home where we could place that resident.
But let's go back to how he got in there in the first place. I thought you were suggesting that it was because there wasn't a room for him. If we already knew this gentleman had these issues and needed help with dealing with that, how did he end up in a women's ward? Like, to me, that would have been the last case scenario of where you would want to put somebody that's showing these symptoms.
So, Mr. Chair, our units have both male and females on our units. So that's standard across our homes where residents, both male and female, reside in the same home area.
So all the other wards would be the same as this with the exception of the all-male one?
That's correct.
So the other ones wouldn't have been any safer for the residents if he had been put in there?
That's correct.
Okay. Thank you. Okay. Thank you, Mr. Auditor General, then, for your report. Going back to the agenda here, so I'll read this out, that the Audit Committee received the reports on investigations into the long-term care homes and recommend that Council consider and approve the report recommendations. Is that received and carried? It is? Thank you. Let's see here. Now into the wrap-up. Right here, yeah. Sorry, so item number 2, which is the status update of the Audit Committee inquiries and motions for the period ending 13th April 2018. Is this item received? Okay. Now, also need to ask that we confirm the minutes for minutes number 14, which were the 30th of November 2017. Can the committee confirm those minutes? Thank you. Any notices of motion? Any inquiries? Other business? Okay. And a motion to adjourn, please. So moved by Councillor Archanter.
Can you just say CPS will start at 12:30?
12:30. Community and Protective Services, just informed by the chair, will start at 12:30 here in this room. Okay, thank you. Thank you all for attending. And thank you, Mr. Auditor General, for your work. If you want to collect